Hello, everyone. My name is Zaheer Babar. I'm professor in medicines and healthcare at Department of Pharmacy, University of Huddersfield in West Yorkshire, and also editor-in-chief of Journal of Pharmaceutical Policy and Practice. My work has been spent about since year 2000 when I started working on drug prices in Malaysia. So I've been working with the WHO and World Bank and with other international agencies on measuring drug prices, affordability, and availability, especially in the low and middle income countries context. So I've done a lot of work in Malaysian setting. So the work which we did in Malaysia actually contributing towards a medicines price control system, which the government started considering to enact a pricing control system. I went to New Zealand in 2007, and then we started a journal which is called a Southern Med Review. And later on, this journal was renamed as Journal of Pharmaceutical Policy and Practice. And this journal has been very instrumental to publish pharmaceutical policy, practice, access to medicines, quality use of medicines, generic drugs, counterfeit medicines, all sorts of health system strengthening perspective, specifically in low and middle income countries. But now we have sort of broadened the remit a bit, and we are focusing on high-income countries as well. Apart from the pricing policy and the quality use of medicine work, in the last few years, I have edited a number of books as well, which are directly related to global health, and some of them are pharmaceutical policy in countries with developing health systems, which is a sort of a country case study of about 20 countries on policies. Another book is on pharmaceutical prices in 21st century, which covers access to medicines and pricing in a global context. So these both books are published by Adis Springer. Last year, we also covered another book, which is called Social and Administrative Aspects of Pharmacy in Low and Middle Income Countries. So we have a lot of aspects related to quality use of medicines, pharmacovigilance, counterfeit drugs. They were sort of all covered in the global health perspective. But I would say that my main contribution has been so far is in terms of strengthening health system is the journal which I've produced, because we have given a lot of chance to people from low and middle income countries actually to publish the work, because they find it often difficult to publish in mainstream journals. So that sort of strengthened the health policy and systems discourse.
The root causes of substandard and falsified medicines are complex. However, how can we best reduce circulation of these harmful products from a policy perspective?
I mean, it's a complex problem with not an easy solution. But I think we need to look at those countries where sort of have successfully managed to curb this problem. And all of those countries, if you are actually going to look at, they are mostly countries with who are high-income countries or who have a very strong regulatory systems in place. So you wouldn't see this problem. For example, I've lived in New Zealand for 9 years, so you can't really take a banana or apple in New Zealand without declaring it. So it's a very strong regulatory structure in place. So you can't really think of having a spurious or counterfeit drugs basically going into the country. So my own theory is that if you have a strong health system, and this strong health system normally goes up with the country's economy or GDP, then you would see that lesser of these things would be available in the market. I would say there is no single solution to that. So I would, in terms of targeted approaches, you could have a very strong regulatory pharmaceutical structure in place. You could have committed people on board, and political commitment is the key. Yeah. If you have a system which is not very wealthy and you want a shortcut, then the shortcut is actually to have politically committed people, corrupt who are not corrupt, and who can actually able to take on this challenge for counterfeit drugs. Pharmacists are the key because they can actually work at several levels. For example, as we are talking about regulatory systems and structures in place, then they are the key, and they work all over the place in terms of in regulatory authorities. So I see a sort of a key role in regulatory structures, sort of some role in the community pharmacist level, but I don't think community, if your regulatory structure is not strong, then community pharmacy, they can play some role, but it's not going to be vital. So I think the regulation, the regulatory pharmacists, they can play a very important role. Another important role, which I think is in terms of education, research, and training. The academia can actually look at to generate the evidence. So the academic pharmacists can work with the students or with the policymakers to actually generate the evidence, because this is an area where there's a lot of hype, but we have very little evidence in place. So to act, first of all, you need the evidence. So pharmacist I see at the three levels. One is the academic pharmacist, researchers, and then you have regulatory pharmacists who are working with the drug regulatory authority in each country. And then perhaps the third level would be community pharmacist or hospital pharmacist who are actually dealing with the patients. We have some, I mean, in the past, we didn't really have much evidence as far as uh, the number or the prevalence of counterfeit medicines. We have a lot of talk about the countries, that this country has 50% of the counterfeit medicines, or this country has 40%. For example, a couple of years ago, there was a WHO document which was saying 50% of counterfeit drugs in Pakistan, medicines in Pakistan are counterfeit. But when we started actually sort of looking at it and started looking at the evidence, we couldn't find the evidence. So it was just a secondary data source or third data. So I think this was really a problem. Now we see that there are some studies which are coming and which are surfacing. You can see some good articles in PLOS Medicine and maybe in Lancet or some other papers. But I still think that there is a need to generate a lot of data on the issue. It's not at that level where it should be, and especially because this problem is mostly in low and middle income countries. And as I said earlier, the low and middle income countries, they have their own problems of generating data, not only on counterfeit medicines, but in any research which is related to pharmaceutical policy and practice, besides many other points. So I think there is a need to do a lot of work in this specific direction. And another point which I would like to add is basically is to have the clear definitions on counterfeit drugs, substandard medicines, and falsified medicines, and then perhaps before starting any research to clear on these grounds that what is really our research question is. I think this is a very good campaign. This is an excellent example because it's actually creating awareness about the issue. So that's the best role it could play. In terms of creating awareness, educating people, educating young students, educating young researchers, so that they can actually, it gives them sort of enthusiasm to actually work in the field in the future, because often in the public policy debate or in the pharmaceutical policy or the overall picture, we didn't really see many pharmacists or pharmacy students interested in this discourse or discussion and debate. So actually it's creating a lot of enthusiasm and energy to focus in this direction. So I would consider this as an excellent example, and maybe another level could be, which it could do, is actually to involve maybe the policymakers who could actually share some examples that what has worked and what has not. Yeah, this is very interesting question because reduced access could create all sorts of problems, not only in low and middle income countries, but even in countries like United States, where you do not have compulsory health insurance and you have to pay. So the people ended up actually importing medicines from Canada and other parts of the world through parallel trade and all sorts of things. So access, if you don't have access to medicine, then you would like to actually use the medicines, then you would go for the options which are not of, and if you don't have available options in the country, then of course you would go for the medicines which are not of good quality. And as a patient, you wouldn't know that they are of good quality or not of good quality. One example is actually in the African continent where you have the antiretroviral drugs. And if you do not have good quality antiretroviral drug and the patient is dying, then of course he would like to take any medicine as a last resource. So I think quality would be the second option. The first thing that the person needs something. So access, not having access to medicines means that actually it may contribute, but that's not only one only factor, but there are other factors as well. But I think it could actually sort of contribute towards the proliferation, using the word proliferation of counterfeit medicines. The public policies, again, we need to learn a lot from the countries where there is a success or there is less counterfeit drugs. So the public policies are, for example, policies in Australia and New Zealand or UK, which is universal health coverage. It means that the patient really don't have to pay much about the medicines and they're getting medicines and it's a universal health coverage. So that's the availability of affordable medicines. I think that's the key, basically. Um, that's one. And the second is that on top, that's not the only thing, but on top of that is the strong regulatory structure, strong border protection, yeah, and also creating awareness for the patients. I think these are some of the points. I think because there are two aspects of it. One is that, as I said earlier, it's an excellent campaign, and as if this is something which I'm very keen and interested as a pharmaceutical policy researcher, and I think it sort of goes into the broader public health domain. So this doesn't really sit within a very short or narrow sort of window. So it has far-reaching implications to improve public health in a better way. So I think that's the reason and to support this campaign.